So, okay, everybody's done with the quiz. As I told you, it's a difficult quiz. And I think that why it's so difficult is it inspiratory stridor? Is it an absence of a sound? Or is it an expiratory wheeze? In coarctation, what's the first thing you look at? Well, if you think coarctation, the only way you're going to even think that if there's no femoral pulses. So that's where you would go. And I'll be going over a little bit more of that quiz. I can't yet on just those couple little things to put in your mind. But there are more students taking that quiz later tonight and on Friday. So I can't completely go over it, but I just wanted to say those things. So something to look at. Now, we are week 6. I mean, we're halfway through and it's unbelievable. It's going quick. Remember, your project is week 8 and next week is your exam. So it's a lot of stuff going on to try to keep yourself organized. There are reviews going on all this week. There's 2 already been done. I do mine tomorrow at 2 p.m. And then on Friday, there are several of them. We have at 5:30, 10:30, and we have one also at 6 o'clock. And then on Saturday at 10 a.m. Eastern time. So they're all over the place. So again, I'm going to post all of them for you and I keep it in one place. You can see how I just opened it up and I just fill it in as I go so that it's one announcement to look at and not 7 of us, because that's how many there are. So that's just too many to look at.
I have a question about your review tomorrow, because I have med surg until I think like 12 20, but I have a doctor's appointment after. Is it okay if I am on Zoom when I'm
That's
at
fine.
the doctor?
That's fine.
Okay.
If
Okay.
you can sit there and listen, absolutely. That's
Yeah.
not a
Okay.
problem.
Okay.
It's just class. You can't be sitting in a doctor's office or a car or driving those things. But this is a review. This is for you. So if you're sitting in a doctor's office, hey, I would like to listen to something instead of doing nothing, right? So it keeps me going, especially if it's that doctor that makes you wait a long time, because I've been in some of those too.
Yeah, it's one of those doctors.
So
is it okay then if we aren't on camera and just listen if we have to like go on a road trip or something?
That's fine.
Okay, cool.
Absolutely fine. I do not
Okay,
mind
I just
that.
want to check.
Yeah, no. I appreciate it. No, not a problem. Remember, it's different. Review is different from the class. Review is giving you that information. So there's a little bit of different, I mean, especially for me, that doesn't bother me at that with a review. So week 6, it's all about hematological, immunological, and there are some child with cancers type of questions there. Now, as I said earlier, I have already done a recording on the PowerPoint. I mean, there's a lot of information here to cover. I can redo the PowerPoint with y'all, or I can do the Kahoots with you. What do you want?
The Kahoot.
Kahoot.
All right, is everybody up with a Kahoot?
I would rather
Yes.
lecture, but if you're going to post a lecture, that will be fine with me.
Oh no, you have a great lecture. I mean, I really went over it in detail.
Okay.
So again, it will be a dual thing where you see 2, and I'll put one will say recording PowerPoint and then Kahoot recording, so you even know what you're looking for. Okay.
Yeah, I'd rather lecture too, but if we have a copy of it, I'm fine with that.
All right. Awesome.
Same.
All right, we will do it that way. So Kahoot, here we go. Unbelievable. Week 6 is crazy. And again, I'm going to be going over those key concepts within this Kahoot that you really need to understand. So you're actually getting a preempt to the lecture, because please look at that lecture. There's a lot of information on those slides. I spent a lot of time making sure they are what you need. This week you have 2 case studies. You have NCLEX questions and getting ready for your exams. So it's a lot of, stuff to get done. Next week, you have your exam, discussion questions, and a case study. And the following week, you have that pediatric assessment assignment. So if you can get a little bit ahead, I would definitely do it. Because you've got community, many of you, that's also hitting you with project. And here we go. Week 6, wow, pediatric hematology and cancer. What statement best describes a neuroblastoma? Well, neuroblastomas are a cancer that actually originates in the abdomen. And before it's going to go to the brain and be a cancer in the brain, but it's already metastasized. So it goes in the middle, usually on the side, it gets bigger in the abdomen, covers the whole abdomen, but by the time we know it, it's already in the brain. The only good thing about it is there's not a lot of neuroblastoma. It is a small quantity of children, okay? What is priority treatment of a newborn with an HIV positive mother? You know, years ago, I mean, you had a baby born of an HIV mother, and these babies will have HIV, right? Well, today we don't have that. I've actually seen triplets where one had HIV, one had AIDS, and one had nothing. It was normal. And why does that happen? Well, there is therapy that we give in the last about 24 weeks of pregnancy up, where we give these antiviral medicines. And then immediately after birth, we are giving these HIV antiviral medicines because we want to improve that infant's immune system. And we've actually seen infants born with HIV end up being negative by 1 year old. They convert. So I think that's amazing that that can happen today, that it's just not that sentence, you will be HIV for life. Nope, not if we take care of it and we treat it aggressively. What are symptoms of sickle cell anemia? Well, sickle cell anemia is those sickle-shaped cells, right? And they're very weird shape. And it's very hard, instead of those little round, smooth things rolling around the vessels and getting through, those sickles get caught. Especially when you're dehydrated. The vessels are really small, right? So that these sickles get stuck and they back up on each other. So that area swells and the area below is not getting blood flow, okay? So what do we do for treatment of sickle cell? Well, if I'm telling you it's usually due to dehydration, lack of blood volume, we want to make those vessels bigger because those sickle cells need more room to get through. We're number one priority is to give fluids, dilate that vessel. Number two, let's put some heat on it, right? Because that vasodilates. And of course, it hurts. I mean, I'm going to have pain medicine in the other hand, but there's always this conflict. Do I give IV fluids or pain medicine? Well, you can treat a symptom, give pain medicine, or treat what the symptom is caused by, which is small vessels. Fill up, dilute those vessels, and give that volume of fluid, okay? So that's the difference between pain medicine and fluid. You're going to give fluid first, and heat helps. Sickle cell anemia affects which cells? Well, what cells are they? And they're red blood cells. I always ask that question, and I have some students who don't know it. So I always put that question there. What kind of hematocrit does someone with sickle cell have and why? I mean, is it high or is it low? Cardiac children have very high hemoglobin hematocrits because the bodies keep trying to make cells for oxygen. But when you have somebody with sickle cell, these cells are irregularly shaped and they die extremely quick. So it is not uncommon that you would have somebody come in with a sickle cell crisis. I think the highest hemoglobin I've seen on a child in a sickle cell crisis was 7. Usually it's 6 or 5. They all require blood transfusions in the emergency room even before they get out. So these children are going to be lethargic and tired and have no energy, right? There's no hemoglobin, there's no oxygen, there's no iron going to the body. So your hemoglobin is low because you're just not making those cells the way they should, and they're dying off, and therefore it's going to be low. What is the treatment for sickle cell anemia? Well, sickle cell anemia, as I said, is when that sickle cell does not go through the blood vessels, usually at a bifurcation, and it clogs up, backs up, and causes swelling and pain, and then some, tissue death because of no oxygen getting there. It is usually due to dehydration. What's one of the things that can cause dehydration besides the normal kid not, hydrating? Fever, right? Many of these children come in with fever, so they need to be treated for that and give the fluid. So IV fluids, number one, medications as in antibiotics, blood transfusions because their hemoglobins are low, and then one of the treatments for sickle cell anemia is bone marrow transplant. Does it work? Doesn't it not? It all depends. I've seen some work and I've seen some have graft versus host going on. So still, it's not completely proven yet. What is the reason children with iron deficient anemia are tired easily? Well, think about that. What does anemia mean? Your hemoglobin is low. What does the hemoglobin have in it? Red blood cells, right? What do red blood cells carry? Oxygen and iron. So if you don't have enough red blood cells, you don't have iron going around. Now, what causes iron deficient anemia? It's nutrition. You're not getting enough iron in your diet. I think one of the questions about, I think it was preschoolers and treating types of nutritional problems like iron deficient anemia on the last study guide slide showed you what? Let's give eggs, let's give protein, and green leafy vegetables, of course, will help that iron to be taken by that child, and hope nutritionally that their iron levels will go up. But if not, we can give supplements. Remember, with iron, when we give it, it is absorbed through the stomach. The stomach acid breaks it down. So taking orange juice with it, it's encouraged because it'll break up the iron into a usable component, and it's absorbed, and it will have a lot better effect on the body. Aplastic anemia includes a depression of which blood cells? Aplastic anemia is a really difficult diagnosis. And it's a little bit of everything. Red blood cells, white blood cells, and platelets. So they're immunosuppressed. They are apt to get infections easily. They have low platelets, which means they're going to bleed. And then red blood cells. It's just that anemic, hemoglobin low, that feeling of lethargy. How do we treat this? Well, we need to, prevent infections and the red blood cells. We need to maybe give blood transfusions or platelet transfusions as needed. And it's a condition that you can't cure. Yes, again, they think maybe a bone marrow transplant, but it's not completely said that that works again. Medicine's still got a long way to go. I've seen a lot happen, but more to go. What is the most common type of anemia? Absolutely iron deficient anemia. And again, it has to do with nutrition. You see it a lot in the adolescents too, don't we? And that's because what do? They get a power bar and they get a bottle of water and they head out for the day. And because they're so busy, they forget to eat, right? So, and of course, what happens at pre-adolescent growth spurt, and they're growing like crazy. So they need that nutrition. So you'll see it in the younger children that are picky eaters, and you'll see it in the adolescents. What causes promiscuous anemia? Has to do with the intrinsic factor and the ability to break food down into components that we can eat, that can be absorbed, that can be used. And that is B12 deficiency. And then usually these children are placed on B12 injections, which replaces the B12 and helps for the digestions of food. Very good. What symptom is the single most common symptom of anemia? Like, why do they bring their children in? And don't say pale, because you can't tell pale on everybody. It's fatigue. And why are they fatigued? Now, this is the real reason for this question. Why are they fatigued? Well, their hemoglobin is low. What does the hemoglobin have? Red blood cells. What does the red blood cells carry? Oxygen and iron. If you don't have oxygen, you're not feeding fuel to the body, so the body's running on empty. They're tired. They can't move. And it's usually that kid who used to be very active and all of a sudden they're sitting there and they can't, and they're sleeping more. That is what brings them to the doctor. Not that they look pale, even their gums or whatever, even their, fingers. No, it is usually that tiredness, the fatigue. When teaching parents about beta thalassemia, the nurse informs that the child is at risk for what? Well, thalassemia is like rectangular shaped cells. The problem with these cells is they burst, like they're very short lived. So your hemoglobin is always on the floor. These children are for chronic blood transfusions. That's how they live, okay? And this is the Cooley's anemia. You're going to see on the slide, there's 4 different sorts of thalassemia, but we sort of look at the major or Cooley's anemia when we think of thalassemia and we're tested on it, okay? So thalassemia is rectangular shaped cells. And again, it's not to do with clumping up, none of that. They burst. So it's their very short life of them. Because again, what's inside a red blood cell? Oxygen and iron. You don't have oxygen, you're hypoxic. And because the iron spewed in there, now this becomes a problem. They can come into iron overload. So they're going to need to have some sort of chelation therapy, which removes that iron. It could be an oral medication, dextran, that can do that. It combines with the iron and you urinate it out. Or it might mean you have to go on this machine. Looks sort of like dialysis, but what it does takes pieces of blood components out, and it could take the iron out and get rid of it. So thalassemia is a lifelong. You can live with it, but again, these are children that will need blood transfusions to live, and that's the treatment. That and some sort of chelation therapy. What lab values would you see with hemophilia? Well, hemophilia has a problem with clotting, right? We know hemophilia, there's 3 sort of factors that we talk about when we talk about what are the types of hemophilia. We have factor 8, factor 9, which is also called Christmas, and we have von Willebrand's, which is also like a factor 8 too. And all it means is that component that puts the Band-Aid on that whatever's bleeding, something's missing. So it still continues to bleed. It's not covered, so it bleeds. So with hemophilia, you're going to see an elevated bleeding time, that PTT, because you bleed. There's nothing to clot it. So it's your blood's thin, it keeps going. But in this case of hemophilia, your prothrombin time and platelet count are normal. All it is the bleeding time that we monitor for heparin, right? Same sort of thing. It's prolonged. Priority treatment for a child with sickle cell crisis is so what did I say about sickle cell crisis? It is veins that are too small, the cells can't get through, and they get clogged up and they back up, and it becomes swelling and all of this pain. Now, you could continue to treat the pain, but you're still going to have pain. You want to treat the cause of the pain, which is very narrow blood vessels. So number one, important priority, IV fluids. Then you're going to put heat on it at the same time, and you're going to give pain medicine after the IV fluid is started, okay? So priority treatment is IV fluids. Dilate the vessels so that blood can start flowing through and alleviate that cause for that pain. What is immune thrombocytopenia purpura? Well, I teach everybody when you see this crazy name, P is for platelets. So ITP, which is the initials for this, P is all about platelets. Again, we know platelets also are one of the bleeding coagulopathies in your blood. It stops bleeding. This is, that puts the clot on so that you stop bleeding. So ITP has to do with low platelets. Now, this is usually caused by an upper respiratory infection, and it could be acute or it could be chronic. If we catch it and we see these little ecchymotic areas, bruising, these children, they say, well, this kid never goes outside. I don't know why he's bruised all over the place. Sometimes they come in with nosebleeds, okay? And that could be that, let's check a CBC. Simple CBC tells you so much, and that will show low platelets. And we can take care of it, and there is a treatment for it. We're going to go into that as one of these. Thrombocytopenia can cause the following symptoms. So remember, thrombocytopenia, P platelets are low. You can bleed. Which one of these symptoms looks like bleeding, right? And that's that petechial hemorrhage, this little purple sort of petechial type rash. You usually see on the legs, sometimes on the trunk, on the arms, bruising, but there's no explanation. And again, that nosebleed, it's sometimes the first thing that tells us something's going on. I'll multi-select. So a child with hemophilia has fallen. The knee is swollen and painful. Treatment would include. So remember, the knee is swollen because it's bleeding in there, right? Because hemophiliacs don't stop bleeding. So that knee is filling up with blood. Remember that blood is caustic to that joint sac and could cause damage if we don't get control on it. So we're going to do that thing called RICE that you do for sprains. We're going to rest, ice, contain, and elevate. That's it to start with. Now, many of these children have home therapy, whether it's IV or some nasal spray, the desmopressin. That could be one of the treatments, but it could be also IV treatment. And you'll see on the tape that I will send you a story about a little boy whose father came in with him and gave that IV treatment. And I've never seen anybody do it better than that. He was as good as I would have done it. So it was quite impressive. But our goal with hemophilias is to stop the bleeding and to protect those joints. We don't want them to get so destroyed that they end up in wheelchairs. What is a priority nursing action for a suspected blood transfusion reaction? I mean, you've heard me say a lot of these get blood transfusions, right? How do you give them? What do you do? Number one, turn it off. If you suspect it, an inkling, doesn't matter if it was or wasn't, turn it off. Number one, that is your goal. And then if you're not sure, get somebody else there or get the doctor there to look. It could be an elevated fever, could be a rash, shortness of breath, could be many different things. Stop it, and you'll always be safe. A child is admitted with neutropenia. Which nursing action takes place? What should you do? What's your priority here? What does neutropenia mean? Something to do with neutrophils, right? What are neutrophils? They're white blood cells, right? You don't have white blood cells, you get infections quickly, right? Number one priority is just hand washing. Hand washing is our first thing that we do. They do not have to be placed on isolation. We are just making sure that we're not giving them germs that we've passed on maybe from another patient. So always washing your hands. And of course, universal precautions would be used. Which symptom would a healthcare professional expect to see in a child with leukemia? Now, what is leukemia? Leukemia is an unproliferated white blood cells. They're immature. So they're making white blood cells, but they're immature. They don't work. White blood cells count will be less than 1. They could be 10, 100, 1,000, and they should be 5,000, 7,000. And we know that white blood cells is all about infection. Many of the time, they'll also, with bruising, fatigue, and bone pain, will also have a fever. Also, your blood counts will be low. So these children will be tired and they're going to be bruising because it affects all of the components when the white blood cells isn't there. I had a girl, my next door neighbor, who that's exactly her symptoms. That and fever on the end, went to the ER and found out she had leukemias. Now remember, there's 2 types of leukemia. There's ALL, leukocytic, and AML, myelolytic leukemia. So AML is harder to treat than ALL, okay? ALL is the one that 80% of children get, but AML is more difficult, but it can be treated. Your child with ALL is the recent lab results, and the platelet count is 10,000. You're nursing action, like, what are you going to do? What does that mean? Well, what does platelet count of 10,000 mean? What is a normal platelet count on anybody? Isn't it like over 100,000? So platelet counts low. Platelet counts low, there means there's bleeding problems. You still have, yes, ALL, they do have white blood cells down, but this is all about that platelet count. P platelets bleeding, that's what it equals. So place on bleeding precautions. What would be some bleeding precautions? No IM injections, right? We don't want to do any injections that we don't need to. I mean, we start an IV and hopefully give everything IV. Soft toothbrushes, we're going to be monitoring their stools and we're going to be monitoring their urine for bleeding. Young children, with bleeding, especially newly found hemophiliacs, protect the environment, right? They can run around. If you have one of those coffee tables with sharp edges, they can cut themselves. So either get rid of them or pat them for these children. So bleeding precautions. A multi-select. A child is placed on bleeding precautions for ITP. What interventions would the nurse do? ITP, again, this is platelets. Bleeding precautions, low platelets. Well, again, no injections. We're going to look for it and we're going to watch the CBC. Because as we're giving treatment for ITB, which is your IVIG, and we're going to be given anti-D, and these things help build up the platelet count. So we're only way to monitor that to see where we are is to monitor the CBC, just platelet count. And it's also, they do treat with corticosteroids. So ITP, they do treat with corticosteroids too, if symptomatic. Child with Wilms tumor, what action by a nursing student causes faculty member to intervene. You know, I've seen one of these in my career, and these are African-American boys, and usually ages 3 to 5, and it's a tumor on their kidney. The problem with this tumor is that you need to protect the belly because the capsule it's in is very fragile. And if you manipulate that abdomen, little microembolus can go off and cause metastasis of this tumor. They don't even do a biopsy of this prior to doing surgery. They'll do chemo, maybe some radiation, and then they'll go in and remove the entire tumor. Now, it is a big surgery, and they have to go through all the intestine. So there's a lot of manipulations gone on there. So you have to watch bowel function post-operatively. And also you have touched the kidney and removed the tumor, right? So watch for urine output. Those are two things. My little boy came from Haiti and we didn't even speak each other's language. And I somehow had figured it out. Again, you're going to hear that in the recording. And he's doing well today. Cancer of the body's blood-forming tissues, including the bone marrow, is called what? And that's leukemia, okay? The body's blood-forming tissues. This is, you know, you do with your red cells and your white cells and your platelets and the bone marrow, of course. This is classic, is what we call leukemia, whether it's the ALL or the AML.
I have a question.
So a child with ALL has a fever of 100.5. What should they do? They're at home. Mom takes the temperature, it's 100.5. Well, think about ALL. What does a fever mean to them? Remember, they have no white cells. They can't fight infection. These children and all of the children with immunosuppression that runs a fever, when they have a fever of 100.5, they are told to call the doctor. Or if it's a weekend nights, get to the emergency room because they need immediate antibiotics. Or they're going to go into overwhelming sepsis and die. It's that serious. There's no defense at all for these children. Get medical attention. A child's having a bone marrow aspiration. What should you tell the child? I mean, whether it's, leukemia or any of these blood type of coagulopathies we're talking about, many of them will do bone marrows to look at, the cells. They have to take and go into the hip or the sternum, and it is deep, and you can hear a push and a crunch, okay? It's, if you've never seen one, the first one you see, you're going to jump. When you see the surgeon or the doctor, you hear a and it like pops in. Now, today we're really good. We do numbing on the outside. We'll do some numbing a little bit deeper, but it's going to hurt a little bit. Today, they do tend to give some sedation to these children, so they're not going to really remember it, but they might. So what do we tell them? Be honest. It may hurt a little, but we're going to do everything we can possible to make it as little as possible. And that's all a child wants to know, what to expect, okay? This is something parents cannot be there for. So this is the nurse holding that child's hand. This is not the parents because it's a sterile procedure. And I wouldn't want a parent to watch that. Most common clinical manifestation of a retinoblastoma. So the retina gets a tumor on it. And this is the way we actually determine what's going on. You know, when you do the flashlight in the eyeballs and we're looking at neuroscience, or even you turn the lights out and you see the shiny white cat's eye reflex, we know that's probably a retinoblastoma. Ever seen your backyard? It's dark out and there's a light on and you see a cat, a dog, a deer, or whatever, and you see those shiny eyes? Well, that's what the eye looks like. Now, retinoblastoma is a really in-depth treatment where they put radiation, where you don't make sure you do not erase those radiation purple marks they put there, and chemotherapy, and many times you have to remove the whole eye. So it is a big surgery, and this requires a lot of TLC by nurses to those parents because they're going to have one eye gone, right? I just can't imagine. So your child's been diagnosed with a retinoblastoma. What information is important to understand about this? Like, what are you going to ask these parents? I mean, we can sort of figure out how long has this child been having symptoms, because it is a tumor that can be metastasized. So the quicker we get it and get it out and treat it, the better, the least chance of metastasis, right? So we want to know any history. We want to know how long that's been going on. That's a very, very important part of the information, and it will give us understanding of what to look for. You know, how many more x-rays or CAT scans do we need to do to make sure that there is no metastasis anywhere? A goal of surgery for a child with an osteosarcoma. Now, osteo means bone, sarcoma is cancer. And many of the times, this is adolescence, and it's the femur, the long bone, the whole femur. The thing with it, you can't just take out the little piece of bone. You've got to take the whole femur bone out. So what are you left with? There's nothing there, right? So what they do today is and there's a picture on the slides that I sent, they take the lower leg, put it on and turn it around, and they're going to use the foot to put in for a prosthesis. So there's something for the child to walk on. It's called salvaging the limb. It's quite intense. This is something in the last couple of years. It's newer. It's better than just doing a complete amputation. Can you imagine taking the whole leg right up to the hip socket? Because that bone's got to go. All you're left with is a socket. So where are you going to attach any sort of prosthesis, right? So with this, I mean, it's a long surgery, but they reattach it and then they're able to get them to the point where they're more mobile because they've got a place for that. So they can walk around better. So true or false? Immunizations causes autism. Absolutely not. Let me tell you where it came from. You know, this is something that went around in the 90s, I want to say, and it still is lingering. There was a physician who put out a study which was false, and he said that usually we do not diagnose autism till about 2 years old. One of the immunizations we give right before them is the chickenpox, the varicella. And he said because the varicella vaccine, they are given it, that's when they have autism. But it had nothing to do with already having autism. We don't diagnose it till then. So they went back and looked at the study, found out it was false. This physician no longer practices. And we have made sure that, you know, immunizations do not cause autism. It's one of those ploys not to take them. I don't know, or looking for an excuse why it happened to your child. I mean, autism is a hard thing that you've got to work with, and it requires a lot of care. So some parents were like, well, at least I know where it came from now. And we don't know. We still don't know. We know it's more boys, but we don't know much more. A child's complaining about those skin markings for radiation therapy should be told what? They're going to take, the eye out, and there's little purple marks on his head, and he's walking around, and they're upset. They don't want him. They need to stay there because then they know where to put the radiation, where to zap the beam, because it needs to go to the same place all the time. So if you wash it off, it's going to take a longer time because they do all this measuring and whatnot in order to place those markings. You take it off and they've got to go through all of those measurements, et cetera, again. So leave it where it is so that we're giving the same treatment, consistent. I'll multi-select. Nursing care of the patient with immune thrombocytopenia purpura, ITP, P platelets, low platelets. What do you do? What is your concern? What do low platelets do to a patient? So it's all about bleeding, okay? ITP has nothing to do with the blood vessels, so you do not need IV fluids, okay? That's only for sickle cell anemia. Remember that one, very important. But no eye injections. We're going to be looking at those CBC counts, monitoring that platelet count. And as I said, corticosteroids are given as needed, sometimes not, but it's one of the treatments that's there. Remember, IV fluids is not ITP. They don't need it. The blood vessels are fine. When distraction is used, it helps what? I mean, distraction is used for so many things in nursing with children. So it's all about, distraction. One of the big things we use it, they're about to have something done, or they're worried about being painful, or they're in pain, and we want to stop their mind thinking about it. Kids are great. Give them some crayons, give them a coloring book, giving them stickers, giving them an iPad, giving them a game to do. And something, they forget about how much they hurt. I mean, always make sure that we give that medicine as they need it for pain, but that distraction with it is a wonderful thing, and it does really, really work. I used to be the queen of distractions. What assessment question needs to be asked to a child with possible rheumatic fever? I always go back to the week before. Rheumatic fever is caused by what? So rheumatic fever is caused by a strep infection that wasn't treated or partially treated. These children come in with rash, fever, sore throat. They could even have the shuffling gait, chorea. But the only thing it cannot take care of, giving these long-term antibiotics to treat the strep, which cause rheumatic fever, is any heart valve damage. It does not correct it. Once the heart is damaged, it is damaged, and we'll need either surgical or medical treatment for it. Signs and symptoms of asthma. This was one of your questions on the quiz today. And when you have wheezing, it is not pneumonia, it is not croup. When you have asthma, you have wheezing, and it's all expiratory. And think of it this way, okay, you have croup, you have swelling in your upper airway. To get air in is hard. It's all swollen, okay? It goes in hard and goes out easy. That's not a problem. So it's inspiratory stridor for croup going in. Asthma, you can get it in there, but inside is all swollen, so it sticks in there. So you can't get it out. So you're forcefully to get it out, like this expiratory wheeze, okay? And because all that inflammation in there, you're coughing, and of course, you're not getting air the way you should, you're going to be short of breath, okay? Difference. Now, pneumonia is a consolidation in an area full of gunk, mucus. That means you hear nothing there. What would you see with pneumonia? Well, fever, and you'd have a cough, but you're not going to have that inspiratory or expiratory wheezing stridor. You'll see a consolidation and no sound over that breath sound, that lobe of that lung. A multi-select. What symptoms should you be reported to the healthcare provider for a child with sickle cell disease? Like, which ones are really important? And because they're serious. So sickle cell disease can be in any blood vessel. One of the normal ones is swelling of the hands and feet. We know that. That's not as serious. We're going to report it, but it's not that important one. What about if it's in the brain and you're sickling in your brain? It could be a stroke. We would be doing neuro checks, right? Very important thing. Another one, chest pain. It could be a pulmonary embolus in there. So when you're talking about sickle cell, there is, the ones in the hands, the feet, the elbows, and knees. Those are the normal ones we expect or we see a lot. When we see headache, we need to react immediately because it could be neuro and we need to prevent that stroke from going on, right? And chest pain, same thing. We need to be protective of that child. And sores have nothing to do with sickle cell. Absolute contraindication for nasotracheal suctioning include which of the following? So if you have an oral airway that's inflamed or have had surgery, you don't want to put anything in there that's going to create more problems. There was a question about what should you do? A kid wants to have something to eat or drink. Well, if you have tonsillectomy, you've got big scabs in the back of your throat, literally big cauterized scabs. So giving little ice chips works. That's great. And maybe little sips of fluid, but nothing red because you want to look at that blood. Now, croup again, oral airways, all inflamed. You don't want to do anything to make it more. And epiglottitis, I mean, you're barely breathing. So that is something that we don't do. Tonsillectomy, no tongue blades in there, but nothing in the mouth, okay? And again, you see swallowing and tonsillectomies, what are you going to think? Bleeding. And that might need some cauterization of that throat. As I've said, I have seen them hemorrhage, literally hemorrhage out of their mouth, blood clots this big on 7-year-old kids. And we had to bring them to trauma room and we had to resusc them with 2 liters of fluid. I'm talking an 8-year-old child, and then get them up to the OR and get it cauterized. So tonsils you don't mess with. Little ice, cold, oh, that's great. Vasoconstriction, perfect. Iron dextran is given which route? And we use this for iron deficient anemia when the oral stuff doesn't work and nutrition doesn't work. So iron dextran is thick, it stings the skin. So we're going to be giving it IM by a Z-track. We do it Z-Track because it keeps the medicine inside. I call it the lock and load. You pull it, give it in, pull it out, and you lock it in there, right? And it prevents the staining of the skin. So iron dextran, IM Z-Track is given. And then the medicine doesn't come on the skin and it doesn't burn it and it doesn't stain it because it will. It's brown. If a child was to receive their own bone marrow, this is called a blank transfusion. Now, when we're talking about bone marrow transfusions and giving yourself or from other people, there's some information that you need to know about it. So if it's my own, I call it autologous. Automatically mine is best. Automatically mine is best. It's autologous, okay? This could be from your umbilical cord blood. Some parents save it for their children. We know that leukemia is that age is 2 to 5. So to save it for that, if there's any sort of history, wouldn't be a dumb idea. It'd be a great idea for that child. Now, allogenic is everybody else, all the others. The other thing is you don't have to have a matching like A positive, O positive thing. It could be any karyotype. So that's the good thing about it for it to be used, okay? So autologous, automatically mine. Allogenic is everybody else, all the others. What cancer may present with a painless, firm, and enlarged cervical nodes? So this is all about lymph nodes that have cancer in them. Now, there's Hodgkin's, and this is important. There's Hodgkin's lymphoma, and then there's non-Hodgkin's lymphoma. Hodgkin's lymphoma is usually from the neck up, and you see these big necks with these big, nodes. You're like, doesn't that hurt? And the kid goes, no. And they're going to do a biopsy of it, and they find those Reed-Sternberg cells in there, okay? So it's painless. It's from here up. Non-Hodgkin's, you don't see the nodes like that. It's diffuse. It's small, tiny little nodes that are in there, cancer cells, okay? So the difference, non-Hodgkin's, you can see it. So non-Hodgkin's, you can't see it. And Hodgkin's, you see those lymph nodes sticking out there. Okay, and you could touch and feel them, usually from the shoulders up. A multi-select. When teaching about sickle cell disease, you would include what? So, I mean, we know that sickle cell, the teaching is all about the prevention of going into crises, right? So we're never going to limit fluids on these children. These kids can drink as much as they want because we want to keep those vessels nice and big and plump. So those sickle cells, those weird shaped shells will keep flowing through there. Of course, that dressing warmly, again, prevents vasoconstriction, keeps the vessels big. Pain medicine, yes, should be done before the pain is too big. In any case, any pain, always make sure they have pain medicine early on. These children are usually given Tylenol #3 that they go home with. And when they get pain, they take it right away so that it doesn't get too bad. And as I've said, they're immunosuppressed. We don't want them to get a fever because, again, they burn up their fluids. And they are immunosuppressed, so they need IV antibiotics or at least oral antibiotics. So they should call their doctor or get into an ER for that treatment. Very good. Thalassemia major is treated primarily with, those are your rectangular shaped cells that die and burst a lot. Remember, the oxygen goes, the iron goes, and they're chronically going from low hemoglobins give them a blood transfusion, it's up, and they're going up and down with their hemoglobin. What happens when a heart has a anemic hemoglobin hematocrit? You don't have enough hemoglobin in there. It works hard, doesn't it? It's going to beat faster. So this is a child who's going to go into heart failure, most likely, because you're going from low hemoglobins, the heart works really fast, and then it gets to be up there because we just transfused them. Give them a little bit of rest, but it goes right back down again. So now the hemoglobin's low, so this heart is overworking. And you can hear the banging of the cells with it swooshes inside, the chest. Elevated heart rate, swooshing signs in their chest, yes. And remember, thalassemia, you're gonna have to worry about the iron in even their diet. You're not gonna give them any extra iron, and they're gonna be getting some sort of iron chelation therapy. The cells are breaking open, putting iron into the blood. So we gotta get rid of it. Does oxygen work? Well, if you have cells, it works. If you don't, does it work better? Again, controversial, just like sickle cell. If you don't have cells, is it going to work? They'll put it on just because, all right, let's put oxygen on them. Does it work? That's the question. Maybe, maybe not. A multi-select. What are opportunistic infections of HIV? I remember when HIV came out in the mid 80s. And I remember I went to work at a county hospital in the medical ER. And I had a patient with HIV go into respiratory arrest. And I remember the nurses saying, oh, they have PCP pneumonia. I'm like, what is that? Remember, it just came out. I hadn't had information on it yet. So I've always remembered it.
Professor?
Yes.
Question. When it came out, were nurses and doctors still not using gloves?
That's when they actually started. I didn't use gloves to clean bedpans up in the beginning of my career. I didn't. And it was in the early 80s, believe it or not, when I was in management at a hospital, and we brought over some Filipinos to the States because we were so short of nurses, right? And they demanded gloves. And I'm like, why do they want gloves for? I never used them. Well, now I understand why. Prevention, infection. Do you see how I'm telling you how nursing and medicine has advanced amazingly? I mean, you don't walk in a room without gloves now and washing your hands and alcohol like crazy, right? Yeah, no. When we knew they had HIV, we would wear gloves.
Were the
Now,
nurses
did we wear a
scared to
mask?
treat
Well,
them?
it didn't affect us, but we did wear gloves. That is an excellent question because I had forgotten about that. You are right. Yes, and the other thing is Candida. They get a lot, in their mouths, and the women will get it into their genitals that they'll have Candida with it too. But the one all about respiratory is the PCP pneumonia, and they get sick really quick and they'll crash. A multi-select. Treatment of an osteosarcoma includes what? Remember, osteobone, sarcoma, cancer. As I said, most of those are on the femur bone. I mean, I've watched documentaries on some really amazing college football players who ended up having osteosarcoma and have to have, their legs partially amputated, which made me remember osteosarcoma. But yes, we can amputate, but our goal is that salvaging, and chemotherapy is also used to shrink it. So to make sure we get all of it. Stem cell transplant does absolutely nothing. Does nothing. It's not for that. A multi-select. Who are the best donors for a bone marrow transplantation? We know siblings, the allogenic, are up there with autologous, which is me, myself, right? Those are the two ones that are up front. And then allogenic, besides that, is all the others. But yourself and your brothers or sisters are your two ones that are the best, but you can't always get that. And believe it or not, it's not mom. What is the most common opportunistic infection for children with HIV? Most common. And it is the PCP pneumonia, and that does follow with the candida. They do get that too, again, but it's part of the PCP pneumonia, and then their drakes get the infection also in the mouth, etc. What would you consider to be neutropenia or a low neutrophil count in children? Now, one of the things about neutropenia, you know, you're going to get many questions on your HESI, on your NCLEX, all about neutropenia, and usually you're getting lists of patients to take care of. And they're going to give you one with a neutrophil count of 500. And then they're going to give you all with a fever. And they're going to tell you all of these other patients, which looks like you should see them. But anybody, I don't care, adult, child, doesn't matter, anyone with a neutrophil count or neutropenia or a neutrophil count less than 500, this is your priority. A neutrophil count of 500 means there's no immune system. And if they have a fever already, that patient, that child is about to crash and burn on you and go into septic shock. So neutrophil count, understand it, you're going to see it again. And remember, low neutrophil count, priority, priority, always priority. A primary characteristic of a brain tumor is... So brain tumors, usually they're vomiting because you have pressure in the brain and the tumor's getting bigger, right? So the vomiting is not related to food or eating at all, and it progressively gets worse. Then you get a headache that progressively gets worse. And when we see it advancing, that tumor is getting bigger, creating more pressure in there. So yes, the answer is your symptoms are becoming worse over time. And those symptoms are vomiting and headaches. And sometimes the way you're walking, your posturing, you know, be falling over type, those things could be also. The optimum treatment for osteosarcoma is what? Like, what do we want to do for that child? So we want to be able to salvage that limb, and we want to do that because we want to give that leg something to attach a prosthesis to. So yes, very, very good. And last question. A child is receiving the induction of chemotherapy. What does that mean? So when you get acute leukemia, what they do is they'll do all of the lab tests, blood smears. They're going to do a spinal tap to make sure there's no cancer in the spinal column, the central nervous system. And they're going to start chemotherapy. And initially, they start induction. And what it is, they could do 2, 3, 4, depends, of types of chemotherapy. And over 4 to 6 weeks, they hit these children with this intensive, you know, strong chemotherapy. And the goal is remission, which means they're hoping to eradicate it all. But not every cell is caught, right? There's always going to be some sneaky little cancer cells somewhere. So then they go on into doing some more chemotherapy, then they go into more prophylactic. But the most important part of chemo is induction. The goal is remission, as in we don't want to be able to really see any cells anymore. And remember, when you give chemo, you're wiping out good cells, good white cells, good red cells, platelet counts. These children will get platelet infusions. They'll be getting blood transfusions. And these children will be on antibiotics like almost the whole time because they're so susceptible to infections. So let's see how we did here. Jess, number 3. Good job, Jess. Number 2, Ashley. And number 1. Whoop, 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 whoop. Look at you, Christina. Good job. Number 4, James and JP. Now we've got a little bit more time left. So you know what I'm going to do? I'm going to do the part of the PowerPoint in those areas I think we need to cover, and I think then you'll be good, okay? How does that sound? Like another half hour and we'll be good. So let me get my PowerPoint here. And what I'll do is I'll just run through it. All right, let's just go through it. Any questions up to this point? Are you all good? With that cahoots, am I making you think a little bit more? Okay, anemia. Remember, anemia, one of the symptoms that we see is going to be that lethargy, that tiredness, and that's going to bring them in. Remember, red blood cells carry oxygen and it carries iron. So if they don't have iron and oxygen, they're going to be tired. They're going to have, no energies. And they call children less than 10, as they call it, anemic. There are these sort of your classifications of anemia, but I'm going to go into some of them, so I'll go past it. As I said, a child with anemia and a low hemoglobin is going to have a lot of room in that blood vessel, so you're going to hear this turbulence. You can almost hear the cells bouncing around in there. It's like, it's not going to be like a normally heartbeat, right? It's more like a swooshing sound. And remember, if cells in the body doesn't have proper hemoglobin and oxygen, you're going to see the child's not going to grow the way it should. It's just, again, they don't have the nutrition. They don't have the blood, the iron, the oxygen they need. We figure out anemia by, number 1, the history and just a simple CBC. We do with anemias, we can treat. Depending on how low it is, we'll give a blood transfusion, but we try to send that child home with different nutrition or iron, especially in iron deficient anemias, instead of going directly to that transfusion, unless they're symptomatic. Again, always prepare the child. And when you're doing your assessments, look at the ethnic background, because we know sickle cell is one and thalassemia is Mediterranean people, okay? Iron deficient anemia, again, it's nutrition. So how are we going to treat it? It's going to be diet and iron supplementation, okay? We do try to help by giving iron fortified cereals and formulas to the infants, but sometimes, kids don't want to eat the things they should. Remember, if 2 parents have sickle cell trait, it's not a disease, it's just a trait, 25% have a chance of having it. What I told you with sickle cell, you need to remember about, and it will help you with the treatment. Remember, it's an obstruction of a blood vessel, usually due to dehydration. And then the cells back up and it swells and it causes pain. So you're going to be seeing, the hypoxic thing. You're going to see that that dehydration. And it could be, how do we get dehydrated? Well, If a kid's out running around and not rehydrating, I mean, I live in South Florida. These kids better be having a water bottle or Powerade at the bedside, right? And they need to be drinking it in between running around, especially with sickle cell. A fever burns up more fluid than we realize too, and stress can cause it. So how do we treat it? Priority? Well, first of all, they need to sit down and rest because they have no energy. But hydration, IV first, heat, something for pain. And they're always going to have some sort of electrolyte problem. So we need to look at that. And of course, blood and the infection, the antibiotics. A lot of the younger kids with sickle cell to try to prevent this infections, they'll put them on prophylactic antibiotics. Usually it's penicillin. And they do it once a day, twice a day. And that helps from ages 2 months to about 5 years. As I said, sickle cell can go and they can live a pretty normal life. But again, they usually die from infections. Okay. That is the leading cause that we don't catch it quick enough. That's why they're told 100.5 get medical treatment. As I said, with sickle cell, early intervention, and then know about that stroke possibility, the headaches, and respiratory problems. And these kids, if you can, they should be able to go out and act like kids, but they need to know to carry their water around or something to keep themselves hydrated, because that's number one, keeping hydrated. Now, thalassemia, as I said, it's another sort of weird shaped cell. Now, this one's a rectangle, and it's a very shortened life. And it is descendants of people around the Mediterranean Sea, okay? So we have African-American sickle cell. These are Mediterranean. As I said, know the Cooley's anemia. You don't need to know the other ones, because usually when you're given questions, it's all about thalassemia major. We usually don't see thalassemia immediately. We know that those red blood cells, you're giving mom at first, but then they start changing into their own by about 6 weeks of age. And how will we know that we need to look at this red blood cells to see what's going on? Well, if they're not having oxygen and iron, they're not going to grow. Just like not having nutrition. These are going to have very, very small children not growing properly. And just a simple CBC can tell us what's going on. As I said, therapeutic management is blood transfusion and taking care of the iron. Those cells burst and all the iron spews into the blood system, and it can be toxic. Prognosis, as I said, heart disease is going to be big because hemoglobin keeps going up and down and the heart has to work. Many times they'll try to take out the spleen on these children, but again, they're immunosuppressed. Many of them can die because of the post-splenectomy sepsis. Aplastic anemia, we work on usually pancytopenia, and that is the hemoglobin hematocrit are low, leukopenia, low white cells, and thrombocytopenia, which means your platelets are low. They treat this with very much like leukemia, and they give chemotherapy, immunosuppressive, they give blood as needed, etc. It's a lifelong condition that means, again, monitored closely and watching for infections. Hemophilia is from mom, an X-linked recessive trait. Again, there's different factors. That means you need all of these certain things in order for blood to clot. And you need a factor 8 and a factor 9 and a von Willebrand. And if you don't have those things, you're gonna not clot, you're gonna bleed. How do we diagnose these things? Well, you're gonna see a kid who bleeds and it doesn't stop easily. That's easy to see, right? Sometimes it's like in the joints, or maybe it's just bruising. What you will see with hemophilia is a prolonged PTT. Now, I can say there's low factors of factor 8, factor 9, but that takes about a week for those lab tests to come back. So the first thing you're going to see is that PTT level, and it's going to look like that child's on heparin, and they're not, okay? Remember, PTT we look at for heparin, so you'll see it prolonged. All the other levels are normal, but PTT is going to be prolonged. We treat it with that clotting factor. You have a low factor 8, there's a factor 8. Comes in a box with a powder and a liquid, you mix it up, you give it IV slowly, and that's the way it's given. Sometimes, and I've never seen it that they've been able just to do a nasal spray. It's usually the factor, that they give, but they do have the desmopressin nasal spray. As I said with hemophilia, it's rice. Protect those joints, the rest, the ice, the compress, the elevate. And again, young kids, be careful. You're just diagnosed hemophilia. Kids run around and bounce off of everything. And if there's sharp edges, either get rid of them or pad them. Prognosis can be really good, just protecting those joints as well as you can. And there is some gene therapy that's on the way, almost there, but not quite. ITP, remember P, platelets. Platelets are low. As I said, it does usually follow an upper respiratory infection. And as I said, there's an acute, which is less than a year. And then chronic is greater than a year. And this is how we treat it. We give IV, IG, and we give anti-D antibody. And then sometimes corticosteroids. And if we have any person, your children, we are going to, and when they're in our care in a hospital, it's all about bleeding precautions, right? Avoiding the venipuncture, watching for bleeding, monitor their CBC, looking where those platelets are, okay? Those nosebleeds can happen. As I said, this is one of the things that we usually figure out what's going on with these kids, that they're having ITP. You have a NCLEX question. It's going to be on the epistaxis. So what do? They bend forward. We don't want them to swallow the blood. We want it to come out their mouth. Hold their finger, the thumb and their finger, hold it for 10 minutes. If it continues, they need to seek medical care because they might need it cauterized, or they even have something they call nasal tampons. They put it in there and they swell, and it's like putting a pressure in there, and they have the strings hanging out. It's like, yeah, they look like they have 2 tampons sticking in their nose, but it works. It does work. HIV/AIDS, I told you that they're given it during pregnancies, 22 weeks, that they start this highly active antiretroviral therapy. And because our goal, we want that newborn to have the best immune system they possibly can. And then we're going to continue it when they're born. Pneumocystic pneumonia, most common. We just did that in your cahoots. And these children, as I said, they should be treated like any other child. And the hardest part, I think, is that confidentiality, that HIPAA, especially when all of these babies are in one room, right? Hey, be careful, put gloves on, that kid has HIV. I mean, it's something you can't say, right? So you have to be very careful with this child. We give a lot of blood transfusions. We do apheresis, which is to remove something, right? Remove something from the blood. This could be the iron, like with that thalassemia, getting rid of it. Or it could be, let's get some platelets from mom to give to the child. So there's many things we could do with apheresis. And again, that bone aspiration. Tell them that you're going to hurt a little, but we'll try to make as little as possible. Again, 2 parents with a trait, you have a 25% that a child will be born with it. So leukemias are that white blood cell, right? It is unrestricted proliferation of immature white blood cells, which means, yeah, you're making white blood cells, but they're not working right. Well, what do white blood cells do? White blood cells fight infection. So what do we do when we suspect it? We will see these children with fever. We'll see them with bruising, joint pain, very common in lethargy too. We'll just do a simple CBC and a blood smear, and we're going to see those white blood cells. They're just immature. They're not working. Then we'll do that lumbar puncture, look at the central nervous system, and of course that bone marrow. So 4 phases of therapy. The first phase, like I told you, induction, 4 to 6 weeks of multiple type of chemo. and we want them to be as those cells gone as much as possible. We want to achieve remission. I mean, we know there's going to be little pieces somewhere around there, so we do a little more, but we want to do it in the first part. The stem cell transplant, autologous is automatically mine. It's the best. And then allogenic, everybody or all the others, is from a donor. And we know the sibling is the best of all of those. Leukemia, how do we treat them? Well, there's no white blood cells. So infection, number one, they're losing all components of their blood. They're getting constant platelet and blood cell transfusion. So worrying about hemorrhage and anemia. And as nurses, we got to be really careful with chemo. You know, I tell every class that I teach about chemo and cancer children. There are so many hospitals that are so need of nurses to take care of oncology children that they're paying like 25,000 sign-on bonuses, $25,000 sign-on bonus once you get that experience. Now you're going to say you can't work with that death and dying of children, right? Hard stuff to do. But it isn't that your child died. You know what it is? What did you do for that child while they were alive? You know, I have many lifelong parent friends of children who have died, and they're still my friends today because of what I gave them at that time. So you can be very instrumental. So yes, I can cry, and I have cried with the parents sitting there hugging them. So it's, you know, yes, it's an emotional part. I mean, you wouldn't be human if you didn't cry, if your child that you were taking care of for the last 3 months dies, right? Anyway, prognosis of leukemia depends on what was their white cell when we started. Was it 100 or was it 500? Makes a difference. How old were they? They're usually 2 to 5 years old. What cell? Was it ALL or AML? And males and females, there is a difference. And the karyotype analysis, are they A positive or are they a very rare blood type? Then when you need those blood products, can you get them, right? If you can't get the platelets and the RBCs, the heart's working more, and you know, there could be more types of complications. So cancer, we can take care of it with chemo, surgery, radiation. The signs and symptoms, I mean, it's cancers like leukemia, pain, fever, ecchymosis, petechiae, bleeding, lethargy, weight loss. All of these things could be signs of cancer. One of the things, as I said, is the infection and being aware of neutrophil counts. Again, here is another slide on it to show you how important it is. This is your priority patient, a child or an adult with a neutrophil count of lower than 500 is your concern. They can go into septic shock. You're going to be doing cultures and you're going to be giving broad spectrum antibiotics, and you're going to be washing hands and you're going to be protecting them. Hemorrhage is huge. That's why they're getting a lot of blood transfusions and the anemia. You know, years ago, I could not give an antiemetic until a patient vomited. Today, we're going to give it before they vomit because we know they're going to. Again, another change in practice, you know, that I have seen. And it does help with that nausea and vomiting on it. Many times these children, you know, don't want to eat. They're not, you know, feeling good. They're, you need to watch their height and weight closely so they're not losing weight, so that we're making sure they get nutrition somehow. And they say their diet should be high protein, high calorie, full fat, because they need all of the calories they can get. And they're going to be eating smaller amounts. So making sure they get jump packed as much as you can in the smallest bits of food. Their mouths can get all sore from the mouth to the anus, can be all irritated. So foods and mouth care. They also, because they're not going to be eating right, they're going to have constipation. We have to be careful because of these low platelets that they can have. We don't want them bearing down. They could stroke. Bearing down because the blood vessels are weak because of low platelets, no hemoglobin, low hematocrit, right? they could burst. So stool softeners, very important. And then of course, medicating them for pain. We know they can have blood in their urine. It's part of these low bleeding coagulopathies. And you know that children, adults, a lot of them, they lose their hair. We know that in children, you'll see dads and brothers shaving their heads off to be with their kids. I used to bring in ribbons. I used to get these little rolls of all different color ribbons. And I'd go in for the day and I'd say, okay, what color are we going to be today? And me and that girl would have the same ribbon colors on. And if they had a sister at home, we'd send one home to them. And you know something? They look forward to that. They didn't remember no hair. They remembered you could really see the ribbon on their head, right? So again, distraction. I'm really good at distraction. Steroids, doesn't matter who's on them. If you're on high dose, especially with chemo, you're going to possibly go into Cushing's. Remember the older kids, these older kids, they're going to have that body image. Make sure that they don't have little tiny little robes on that, you know, you push and pull your shirt when it's too tight. You don't want to do that. So give them the extra large robes so they can be covered, right? And they don't have to pick their stuff and be self-conscious. It makes a difference. Make sure that they're ready for procedures and make sure that we use every numbing cream, everything that we know. You having parents hold them as much as possible, decreasing all the pain and stress of this, because it's going to be a long-term care. It's not just one day, it could be 2 years. Take care of their pain. I mean, small doses around the clock. Keep giving them what they need. And again, remember, pain isn't just that medicine. Distraction is amazing. Also, it could be elevating the head of the bed if their tummy hurts. Maybe a hot pack, a cold pack, giving them something to do, crayons and colorings and iPads and all that good stuff. We talked about lymphomas, Hodgkin's, remember? Do you see those big swollen glands in there and those lymph nodes? Painless, they don't hurt. Because of all the swelling that's going there with those lymph nodes, that's the cough. And because of that, the anorexia, they're going to have fever and weight loss. So again, how do we fully diagnose that? It's the biopsy, presence of Sternberg reed cells. And that's when the diagnosis is made. We give radiation, chemo, and usually they do really well. Now, non-Hodgkin's, you don't see it. It's diffuse. It's not big lumps. So that's the difference. If you see, if it's painless lymph nodes, that is Hodgkin's. Non-Hodgkin's, you don't see it, but it's all in the lymph nodes all over the place. Again, this thing's here. We do treat it more like a leukemia with radiation, chemo type of stuff, and that's with non-Hodgkin's. Remember, non-Hodgkin's, they have a chance of infertility as they get older. Brain tumors, what did I say about brain tumors? You are going to see that symptoms progressing, as in the vomiting and the headaches are going to get worse over time. Remember with brain tumors, post-operatively, you have a piece of tissue that was removed. Know what side you can lay that child on, how much you can elevate the heads of the beds. And these parents need to be prepared what they're going to see. I mean, can you imagine have a kid coming out with things sticking out of his head? I mean, that could be really scary. So make sure the child knows and make sure the family knows. And again, try to get these kids back to their normal. Many of these kids with some therapy can be normal to where they were. This is that neuroblastoma. You see that little baby's abdomen? It was a little tumor that became big, but by the time we notice it, it's usually, we'll see the bulging of the eyes and ecchymosis. And by that time, it's already metastasized. So outcomes aren't good at all. Osteosarcoma. Usually we have a kid complaining of a limp, pain in the knee, pain in the leg that doesn't get better in time, like an arthritis type thing. And what do? Again, we're going to start chemo, shrink it. We're going to do surgery. We want to salvage that limb, right? We need that for prosthesis. Now, another tumor is Wilms tumor. Remember I said this is on a kidney. It is a round ball, like a balloon, and we don't want to touch and palpate it. Big signs everywhere. Do not palpate the abdomen. And if you're changing diapers, you got to be really, really careful on these children. These kids, there is no biopsy pre-op. They just do chemo or radiation, and they go in and do the surgery. And as I said, after surgery, because it's an intense surgery, they're going deep into the abdomen. Be careful of monitoring their bowel and their urine. Now, rhabdomyosarcoma, it's just one slide on it. It's these little tumors in the eyes and the nose, the gums, the ears, and these things, again, they have to go in and remove them. And it's a long-term chemotherapy. The retinoblastoma, that cat's eye, open the back door at night and you see an animal outside and you see that shiny light, that's what these kids look like. We treat them, again, there's that little purple mark for radiation, chemo, and we go in there and sometimes we have to remove the eye and they'll get a fake eye. Germ cell tumors, excuse me. We do breast exams on women. Well, men should do testicular exams. I met an 18-year-old boy who came in with testicular pain into the ER, pulled his pants down to examine him after we'd done the other assessment, and his testicle was the size of a softball. We did an x-ray of the chest and abdomen, and he had already metastasized, and he actually died within 3 months. He was that far gone. So testicular cancer is just by doing those self-exams. Liver tumors, liver grows back. You take out the tumor and they grow back. Yes, it's a big surgery, but at least the liver, takes care of itself. No, cancer used to be a death sentence on all ages, right? Today, survival's at least 80%, at least, probably a lot more than that. We know that treatments are getting better, and we know that we're doing better outcomes on these children. This is my favorite post that you see on social media, those cancer-free. I mean, you look at that kid, they're smiling, and they've been through a heck of a lot, and they're still smiling. Wow, I got through the whole PowerPoint and gave you the rest of the stuff I didn't get you. So we did it all today. Good job. Any questions at all? Well, we did it, and I'm done. If there's no questions, remember, come to a live review, and I will be posting them, okay? Thank you, everybody.
I'm sorry, what time is review tomorrow again, you said?
2 p.m.
Okay, thank you. Good night.
Good night.